Our next speaker is Richard Spade, also from New York, on a new meta-analysis of anti-VEGF dosing in AMD.
I'd like to thank the organizers for allowing me to speak at this meeting. These are my disclosures. So, monthly dosing of anti-VEGF agents produced tremendous results. It was really like a triumph of medicine. So we as a profession pretty much came up to the idea that patients will never do that. So we try to think of ways to give the dosing less frequently or more conveniently to us and maybe to the patient as well. And we did that according to some kind of plan, either treat and extend or PRN dosing. We don't really know how often to give the drug to get an optimal result. We don't have any really data to show this. Now we can look at the results of past studies, and one group of studies are systematic reviews. In a systematic review, the same basic handful of randomized trials are all reported, and they don't look at anything else. They don't look at patient series because that's a lower level of evidence. So they try to restrict the number of studies that are used in a systematic review. Curiously, even though there's only a few randomized trials, there have been 35 systematic reviews about ranibizumab or aflibercept, and there's been 2 systematic reviews of AMD treatments. This guy is Francis Galton. He was kind of an amazing guy. He invented a lot of the statistics that we use today. So he invented standard deviation, regression, the idea of using R for correlation and that sort of thing. He eventually got knighthood. And then he published an article in Lancet about the weight of a bull. Now, I know you're thinking, like, Spade, what are you doing telling us about cows for? But this actually is a landmark study. So what they did is he got a few experts to guess the weight of a bull, and he went to a county fair and got 800 people to guess the weight of a bull. And the experts were pretty close to the actual value of the bull. You can see that actual value was gray. They were distributed pretty close to that. And the average people, just making their own estimates about that, were really had wild variation. You can see the average error for the experts was pretty small. The average error for the regular people were quite large. Here's the counterintuitive part. If you took the average of the experts, their guess was kind of close to the real value. If you took the average of everyone put together, their estimate was 1 pound off of the true weight of the bull, and this has been repeated a number of times. This basically forms there's an easy way to think about this, I think, is that every estimate is kind of a mixture of fact and maybe bias and error. If you have a lot of wide-ranging opinions and average them together, all that stuff average out, maybe the fact remains. Yeah, this is a basis for crowdsourced statistics, which I think you're all exposed to every day, and these kinds of crowd-based voting methods and the like are much more predictive of what goes on actually and the popularity of things than experts would give. So let's compare that to what we look at in studies and systematic reviews. Systematic reviews are essentially discounting patient series, so they're only looking for those experts. And I thought it'd be a good idea to try to adapt that strategy with crowd-based approach and just look at every study that was done with ranibizumab and aflibercept, as long as they didn't change the drug. They were newly treated patients, and they had 1-year follow-up. And you get something that looks like this. There's 122 different studies. They organize themselves certainly into certain kinds of groups. These are the people who had monthly dosing. In red, the people who had treat and extend dosing, and in green, PRN dosing. And there was a statistical difference with those. Now, you may notice there's some yellow dots. Those yellow dots are people said, I did PRN treatment or at discretion of physician. How do you know what that means? But the curious thing is that we know that if we look at dosing of many kinds of drugs and look at a log transform of that, we can get a straight line. And that's what happened here too. It's the mathematical formula for that is shown on the bottom, but there's one easy rule of thumb, and that's pretty much 1 extra injection per year, you get 1 extra letter of vision in the final result. So you can see we kind of pick the result for our patients, or we work out that together either explicitly or maybe implicitly. We can pick the results of what our patients get by how often we give that drug. After controlling for the injection frequency, the drug type or injection strategy didn't matter. So if you use PRN, if you use treat and extend, anything, if you gave, say, 8 injections per year, you're going to get a certain result. 9 injections per year, you're going to get a certain result. It didn't matter how you came up to that conclusion. So let's look at, with that idea in mind, let's look at some logic that we use for treating patients. One is patients don't need that many injections. But really only, you can say also that some people don't need to wear seatbelts when they're flying airplanes, or don't need seatbelts when they're driving a car. And the problem is that we're not really smart enough to predict the future. We don't know that the greater number of doses yields a better result. Now, maybe if we start a higher dosing frequency, we can pull back with the treat and extend approach, but still it's the greater number of injections yield a better result. Another one is that OCT guidance saves billions of dollars. You'd save more money by not giving the drug at all, but you get what you pay for in a sense. The greater number of doses you give, the better result. And this is true for pretty much everything in life. You do get what you pay for. You say treatment is a burden to the patient. But you know what? The disease is a greater burden than that. You can think of that decreased vision, decreased quality of life, and decreased ability to do activities is certainly much more of a burden than get an injection in your eye every once in a while. And patients routinely rate the disease much more of a burden than doctors do. So it's possible that we can compute some optimal number of injections based on the utility of vision and this dose response curve that I just showed you. Maybe 8 injections is the right number. Maybe 9 injections is the right number. We still have to calculate that. But it'll form a conceptual guideline for how we treat patients. We can, right from the start, tell a patient that the optimal number of injections that they may need in the course of a year is 8. That sets a kind of a framing for the patient to understand what they can expect over the next year. I think it's good if we tell a patient that treatment is really an opportunity. It's not a burden. It's an opportunity to keep their vision and keep their life. And finally, this lets people mentally plan out what their treatment is going to be right from the first visit going forward. With that, I'd like to thank you for your attention.